fractures, and the patulous posterior soft tissue is these chronic injuries. So soft tissue balancing can be difficult. It's also unclear if a hemi or an anatomic total shoulder is the best treatment option for these patients. Again, because of small numbers, it's hard to make any type of, or design any type of comparative studies. Lastly, despite projected improvements in pain and external rotation, patients really just aren't that satisfied with their end result. All right, so I just went over a lot of information. How do we synthesize all of it? This is a nice treatment algorithm that was published in 2014 Yellow Journal Review. So just going through the flow sheet, all posterior dislocations, you get a CT. If there's a fracture, you want to consider open reduction to prevent fracture displacement. If not, you want to proceed with closed reduction. If the shoulder is stable after reduction, there's a minimal bone defect, you can treat these patients non-op, mobilize them in external rotation, and then that's going to allow for the posterior tissues to scar down. If it's reducible but unstable or irreducible, you got to operate. Small lesions can be treated with the modified McLaughlin. Medium-sized defects are treated with either modified McLaughlin or allographic construction, and then arthroplasty is reserved for large defects. All right, to summarize, these are rare injuries. Existing literature is of poor quality. There's a lack of evidence-based guidelines to dictate treatment. Most current recommendations are based on just small case series and expert opinion. In the ER, you always want to get an axillary for any shoulder injury. You don't want to miss a posterior dislocation, and delayed diagnosis can greatly impact treatment and outcomes. Again, small defects can be managed non-op, medium-sized need a subscap transfer, and then bigger defects are managed either with an